Great, wonderful. Good afternoon, everybody, and welcome. Lovely to have you all here at our weekly hematology deep dive, and we're quite excited about this afternoon session because we've got two speakers who have actually given their talks before, so we can almost say we've already been able to make sure that the quality is going to be amazing. Both for Prof. Robenheimer and for Dr. Herman Bagula, who's spoken at our Thursday internal medicine meetings recently at the University of Cape Town. So I'll introduce them in a minute, but before we get to that, just a few housekeeping things and just to share with you how the afternoon will work. So the session is a session we do every week for the whole hematological community, and I can now really call it a SADC meeting because all our colleagues from hematology colleagues from neighboring countries and South Africa are joining in every week, which is great. And even beyond, nice to see you, Matthew, from Vancouver, even though you're under a special code today, I see. Great that you are here. And the idea is that these sessions are really focused on trainees, both in the lab, Hempath and ClinHem, and anyone else with an interest in hematology. So you're all super welcome and also very welcome to share this invite every week as you receive it. It is CPD accredited, so at the top of the hour, we usually put a link in the chat box. You click on that, and there's a few details to fill in. It takes about 30 seconds. And then you are registered for CPD, which we send directly to the HPCSA. Afterwards, the recordings are hosted on the UCT Vula site, and we'll also put Melanie Davids' email address in the chat so that you can contact her if you are not sure or if you haven't accessed those before. Great. So we don't want to waste any further time. So what we are doing today is something slightly different. And we're going to focus on diagnostic reasoning, and we're going to jumpstart this with a case presentation by Dr. Herman Bagula, and who is going to share a type of case that we come across, unfortunately, I think too often in South Africa, where this challenge of some common infectious diseases are easily confused with hematological disease. And that's going to be a short presentation with two cases. And then after that, I will introduce Prof. Peter Robenheimer, who is going to speak to us about rational diagnostic reasoning. So Herman Bagula is a registrar at the University of Cape Town. He's got quite a diverse set of interests, amongst others, machine learning and artificial intelligence and how to apply that to medicine. He's previously done some research in air pollutants and also recently spent his rotation at hematology. And we hope that he will follow his dream that he's now got of becoming a hematologist. We'll try to keep that alive. But without further ado, welcome, Herman. Thank you for being willing to present this afternoon, and you can share your screen and the floor is yours.
Thank you very much, Prof. Can you see my screen?
We can, thank you. It's perfect. You can just put it on your presentation thing and ready to run.
Okay, perfect. Thank you for that introduction. My name is Herman Bagula. I'm one of the medical registrars in the internal medicine department. I'll be presenting a talk called The Elephant in the Room, and I hope by the end of the presentation, you guys will all understand why. So my first case is Mr. SB. He's a 30-year-old father of one, HIV negative, with an excellent baseline, heroin user with an appendectomy in June of 2021. He was referred to us in February of this year with a history of dyspnea at rest, pleuritic chest pain with associated non-productive cough, and importantly, no hemoptysis. When we saw him, he was tachycardic with a pulse of 135 beats per minute regular. He was tachypneic but saturating at 95% on room air. He was wasted and had generalized rubbery lymphadenopathy. He was ecteric and was also clubbed. Importantly, he had features of superior vena cava syndrome with a positive Pemberton sign and distended neck veins. He also had this massive right pleural effusion with ascites, and importantly, on neurological examination, no localizing signs and no Horner's syndrome. So this is his chest X-ray. When we saw him, you can clearly see the right massive pleural effusion. And if you look at the biochemistry on that effusion, it was clearly exudative with a negative TB workup and no bacteria. So at this stage, we assessed him as a 30-year-old male, HIV negative with an ECOG of 0, now with likely lymphoma, likely stage 4 as evidenced by the right pleural effusion complicated by superior vena cava syndrome. Our differentials at this stage only included lymphoma. So he had a lymph node biopsy, which confirmed nodular sclerosing Hodgkin lymphoma. We started him on tumor lysis prophylaxis, high-dose steroids, and initiated chemotherapy. So now this case seems straightforward until you realize that this is a young gentleman, HIV negative, who's clearly presented quite late with a disease which is very much curable. So what we wanted to know was, were there any signs that we could have picked up earlier that could have assisted in us diagnosing him earlier and also starting treatment earlier? And so we went on history, and he actually gave us a history of having been to a GP 5 times before June 2021, where he was tested multiple times for HIV and discharged home on antibiotics. In June of 2021, he presented to one of the peripheral hospitals, complaining of constitutional symptoms, abdominal pains, and that actually had this chest X-ray. So just briefly, there's no tracheal deviation or airway cutoff here suggesting a bronchial carcinoma. He's clearly got a widened mediastinum with a silhouette sign. No cavities, nodules, or consolidation. So our presumed diagnosis when looking at this X-ray for the first time would probably be lymphoma. So an approach to a patient like this, after seeing an X-ray like this and the patient presenting with what seems like constitutional symptoms, a logical approach would be to look for peripheral lymph nodes to biopsy, where you do an FNA as well as core biopsy. If you can't find peripheral lymph nodes, look for intra-abdominal lymph nodes that can be biopsied laparoscopically, otherwise mediastinoscopy, right? So unfortunately, he was diagnosed as appendicitis and discharged home with ongoing constitutional symptoms. He actually represented to the same peripheral hospital in September of last year, where he had multiple workups for TB. You can see September, he had the sputum, which was negative for TB on Gene Expert. In December, again, they sent a sputum, which was negative on Gene Expert as well as culture. They tapped his pleural, and if you look at the X-ray, previously you can see there's no pleural effusion, and it's actually progressed to this massive right pleural effusion, which was tapped and also tested for TB, which was obviously again negative. He had FNA, FNAs on peripheral lymph nodes, and cytology also was negative for malignancy until February of this year, when he presented to us and actually had a core biopsy on a peripheral lymph node, which he's actually had since March of last year, which confirmed this nodular sclerosing lymphoma. So just importantly on this slide, just to remember the whole notion of poor diagnostic accuracy of FNAs for lymphoma and the importance of having a core biopsy. So the second case is a Mrs. G case. She's a 45-year-old female, HIV negative, again with an excellent baseline. She's got no known comorbidities and no surgical history. She presented to her presenting hospital with a 1-month progressive history of dyspnea and declining effort tolerance. However, no constitutional symptoms, and she was diagnosed as asthma and discharged home. She represented to them in extremis and was actually referred to us. When we saw her, she had a mediastinal NAS. She was in cardiac tamponade and had bilateral pleural effusions. So our first objective was obviously to stabilize her. She had a therapeutic pleural tap, a pericardial window for this cardiac tamponade, as well as a pericardial biopsy. Again, just a reminder of the approach to a patient like this. This is obviously a patient in extremis. So TB isn't your first likely diagnosis. You look for peripheral lymph nodes to biopsy. And if unable to find peripheral lymph nodes, you look for intra-abdominal lymph nodes that you can biopsy laparoscopically. Otherwise, you send the patient for mediastinoscopy. So this is an X-ray at the presenting hospital. You can clearly see the trachea is deviated to the right. She's got a widened mediastinum with a silhouette sign. She's got a globular heart, as well as this large left pleural effusion. So our differential here would be lymphoma with a differential diagnosis of lung CA. TB was excluded here because we learned about the whole concept of massive pleural effusions deviating the mediastinum, usually not being due to TB. They call it a non-necessitating pleural effusion. So workup at the presenting hospital clearly shows also she's got an exudative pleural effusion with no bacteria, with a negative TB workup. So with us, she had cytology done on the fluid, as well as TB workup done on the fluid from the pleural effusion, as well as cardiac effusion, and they were all negative for TB. She then had a biopsy of a supraclavicular lymph node, which confirmed non-Hodgkin's lymphoma. So just a take-home message with these two cases is to always think beyond TB. These were both HIV negative patients, right? And so applying the TB algorithm to a patient presenting with a massive pleural effusion who's HIV negative can have deleterious consequences. If lymphoma is suspected, consider hematology consult even prior to histological diagnosis. And then the FNA in combination with a core biopsy is key for the diagnosis of lymphoma. Thank you very much.
Thanks so much, Herman. I think that was a wonderful introduction to set the stage for Prof. Robenheimer's discussion now. And unless there are any questions at this point, I think we can move straight on. Feel free to put any questions or comments in the chat. I can perhaps just quickly ask, are there any quick comments for Herman at this point?
Can I just quickly weigh in? So obviously Herman and I have looked at the case together. So I just thought that there is some emphasis that he may not have brought out unless I missed it. Namely that people are not looking for peripheral lymphadenopathy in such a patient. It was present, but they don't look for it in one of the patients. The one patient had FNAs done, but he had another patient that he also presented that where it was not looked at. It's not looked at in the right way. And I think that is an important, whether a lymph node peripherally gets FNA'd continually for no reason whatsoever with the wrong tests, or whether the patient's not examined. You would think with a mediastinal mass, there would be a different way of looking at a peripheral lymph node. And I think that's just something that I hope that we can, because, you know, it's been so impressive when I heard Peter speaking on all these definitions of how we approach diseases. It taught me a lot. So, you know, I just brought this up because this is also one facet of what we do not, you know, it's a very common thing. I'm not speaking of the funny, weird things like doing a medianoscopy or getting a radiologist to do a biopsy or doing a VATS procedure with the cardiothoracic surgeons to get to a diagnosis. We're speaking of the very simple things that seem to get lost in the midst of everything. And I think that would be really cool if that's something that we can measure when, as Peter speaks and as he gives definitions. That's just from my side.
Thank you, Estelle. And I think, yeah, we shouldn't shed too many tears about not having microarrays and next generation sequencing if we don't use the best tools of them all, which is our hands and our ears and especially our brains. And with that, I'd like to introduce, and it's my great pleasure to introduce at our meeting for the first time, Prof. Peter Robenheimer. Peter is the head of the Division of General Internal Medicine at Groote Schuur Hospital, University of Cape Town. He's a specialist physician and an endocrinologist, and also the convener of the registrar training program and the MED for general medicine in the Department of Medicine. And he has a specific interest in system improvements and public health. And I can, from what I know, quite a few other things as well. Peter, welcome here. Really great to have you. Thank you for agreeing to share your wonderful talk with us. And you're welcome to share your screen and take over from there.
And thanks, Vernon, very much for the invite. Amongst all those other things, I'm not an expert educationalist, but clearly hematology is very interested in clinical reasoning, because I listened to your talk a little bit before mine and drew some inspiration from it. So I hope there's something slightly different and slightly new here for everyone to listen to. And I'm going to just take my video off and then share the screen.
You're now on presenter view. I don't know if you...
I'm going to swap displays.
There we go. Perfect.
Okay, so this talk to some extent is directed at teachers, and of course at all levels really of clinicians who are involved in diagnostics. From undergraduate to postgraduates, but as a postgraduate and a consultant, we're all teachers, and if you understand, then you can teach, and if you don't understand, then you can't teach. So I hope there's something here for everyone. I'm going to talk about. If I can change the slide. This talk really focuses about rational, so reasoning, how we think. I'm going to focus on diagnostic, but particularly this is about clinical reasoning, so clinical diagnostics. Although I'll mention a little bit about tests and about excellence, which is nowadays really defined by lack of error, not so much about the old consultant who always impresses you with their clinical reasoning skills. And something that's bothered me is that there seems to be a gap between doing and teaching reasoning. All of us do reasoning every day, and we seem to assume sometimes that teaching clinical reasoning is simply part of everyday work on the wards or clinics. But I think teaching what we do is hard unless we have the vocabulary to describe it. We know the processes, and as I'll show you, we're okay being vulnerable in front of others and acknowledging weaknesses and mistakes. And I'll also show you that I think sometimes the way we teach students contribute to deficiencies in clinical reasoning, the sort of systems approach that we emphasize, how excited we all get about uncommon diseases, and we don't often differentiate them from common diseases. The instructors are expert learners, and we omit information for the novices. And assumptions are often made that students can recognize the more important problems. We don't quite understand why a student who's taken history, examined a patient, and got exactly the same information as you have actually can't come up with a diagnosis. So I hope this will give you some information towards that. As said here in this paper, clinical teachers need to understand their own clinical reasoning processes, as well as be able to convey that knowledge to their trainees. At the same time, they need to understand the developmental stages of reasoning and be able to nurture each trainee's own expertise. So I hope this talk will have something for everyone here, from the medical student to the expert diagnostician and teacher. And if we talk about clinical reasoning, what is it and why is it important? It's really just describes the thinking and the decision-making processes associated with clinical practice. And it's that integration of the knowledge, the skills using reasoning to come up with a clinical diagnosis. And it's our ability to make decisions based on the available information that includes history and examination, and sometimes test results, often against the backdrop of uncertainty. And we like to include that it also includes formulating and communicating these effectively with the patient and or their carers. Very important. And one can look up curriculums for that. Here's a consensus statement on behalf of a UK Clinical Reasoning in Medical Education Consensus Statement Group. And it's, this is what you need to teach around clinical reasoning. Clinical reasoning concepts, which I'll cover some of today. History and physical examination. I think we, bedrock of what we teach on the wards to our undergraduate medical students, and in my view, perhaps a little bit too little in postgraduate students, although certainly examined on it. Problem identification and management, choosing and interpreting diagnostic tests, and shared decision-making, again, involvement of the patient and all their family and carers. And broadly speaking, we can divide it into diagnostic reasoning and management reasoning. And diagnostic reasoning is generally correct or incorrect. Not as perfect as that, but that's really the aim. But management reasoning, there are often many reasonable options, and one needs to negotiate a management, and sometimes with the patient or sometimes in a multidisciplinary team. So it's slightly different. I'm not going to discuss that today at all. So the process of reasoning is really very simply from the patient symptoms, who comes to you with a complaint, my head is pounding, to the clinician making a diagnosis. And we need to connect our book knowledge about diseases, and it's not just really what you've learned in books, but also what you've gained from clinical experience, together with information, using some sort of logic to come up with a diagnosis and treatment. And this is a widely published and quoted algorithm for how the process works. I'm going to show you a different version of this a little later on, but essentially we start with a patient's story. We acquire data, perhaps the single most important step. Without that, there can be no reasoning. We develop an accurate problem representation, from which we will then generate a hypothesis, and then we search for and select illness scripts. These words I'm using very deliberately, and I'll show you what they mean later on. And this is an iterative process for which we eventually come up with a diagnosis. And why is it important? Well, you know, Newland wrote that it's the most critical of a physician's skills. It is every doctor's measure of his abilities. It's the most important ingredient in his professional self-image. Certainly, that's what makes a physician. Diagnosis is what we're about. But you'll see me refer to the ultimate problem solver throughout my talk, Sherlock Holmes, and he often said it best. He said, "I cannot live without brain work. What else is there to live for?" And again, as physicians, one of the reasons we chose this path is, of course, we enjoy this process of diagnostics. And it's important, well, of course, accurate diagnosis is key to identifying the treatment that will restore your patient's health. Somewhat luckily for us at the moment, a computer's ability to prioritize based on the patient in front of you is very limited. Computers are good at generating lists, but so far they have failed at both diagnostic and management reasoning. For example, IBM's supercomputer called Watson, Watson Oncology was a big development program at IBM, which has been abandoned because it essentially gave unsafe treatment recommendations for oncology patients. So computers haven't been able to do this yet. Despite widespread availability of tests, history can lead you to the correct diagnosis in the majority of cases. And furthermore, when tests are needed, the significance of their results cannot really be gleaned unless you know the likelihood of the disease in question before the test is obtained, and I'll show you that briefly. And you know, we all know the problem of defaulting to tests. This is a patient who saw in the clinic the other day, Mrs. Marga. She presented actually to surgery with my stomach hurts. She had a CT scan which had a right adrenal nodule, which resulted in extensive laboratory workup, which ultimately came up with a diagnosis of a non-functioning adenoma. And of course, she still has episodes of abdominal pain. Spent a lot of time, a lot of money, and none of it actually solved her problem or was relevant. So really, preceding any tests with a clinical assessment is absolutely essential. And good clinical diagnosticians, just to summarize what they do, and then I'll show you how that works, sufficiently obtain enough information from the patient to make an initial differential diagnosis. And they search their memory or resources to identify possible causes of their patient's symptoms. They prioritize the likelihood that a possible disease explains the patient's concerns, and then they judiciously use tests to evaluate their assessments, and they continuously analyze the success of their diagnosis to improve the accuracy going forward. And these steps you'll see me emphasize throughout this presentation. The other reason it's important is because we now function and work in the era of patient safety. And it's important for us to recognize that diagnosis is wrong 10 to 15% of the time. You've just had some case presentations of exactly that. 85% of diagnostic errors are considered preventable. And in fact, diagnostic error is more likely to lead to harm than other types of error. So here is a graph from a very large physician insurers database in the US of the top medical errors resulting in death. And you can see here that errors in diagnosis is the commonest cause of medical error resulting in death. And it's much more common than others that we very frequent to discuss, and it's probably easier to describe, such as medication errors here. So diagnostic errors are costly and they often result in harm. And the causes essentially are three main groups of error: no-fault errors, or can't do anything about it; system failures; and human cognitive error. And human cognitive error results from knowledge gaps. For example, you can't have biliary colic because the gallbladder is removed. That's misinterpretation of diagnostic tests. For example, in neurologic emergencies, I trust my MRI rather than my clinical exam. And then cognitive errors and biases, confirmation bias, etc. And I'll show some of that now. And cognitive errors are responsible for 75% overall of diagnostic errors. So the way we think and reason is the main cause of diagnostic errors, either on its own or as part of a system-related and cognitive factor. Either available data was not adequately gathered, or the available data was gathered but not synthesized correctly. If we look at the most frequent misdiagnoses amongst physician-reported cases of diagnostic error, you'll see the old bugbear, pulmonary embolism, right on top. The one we struggle with because it has very few sensitive or specific findings for that diagnosis. Drug reactions, lung cancers, acute coronary syndrome, and these can be broadly divided into vascular, cancer, and infection. And that's no surprise. Those are the three big conditions of premature mortality in adults. And again, you've presented some of those cancer misdiagnoses. So cognitive error, we're thinking wrong, is a failure in rational or logical thought. And it's often due to biases, also known as dispositions to respond. And about 50 known biases exist. They're universal, they are predictable, and they can be corrected. A step called cognitive debiasing. So here's one example, such as overconfidence, a very common bias in physicians. Of 270 patients who died in ICU, physicians were asked to rate their degree of certainty about the diagnosis into three main groups here. They were completely certain of the diagnosis. There was some minor uncertainty and really major uncertainty. Weren't really sure what was wrong with the patient or why they died. And when physicians are completely certain about the diagnosis, on post-mortem, they were in fact only correct 60% of the time. Very few physicians will recognize that within themselves. And of those, the percentage with fatal but actually potentially treatable errors was only 10. So this has major impacts on mortality in ICU and very similar, in fact, in many other settings. Sherlock Holmes himself, and Sir Arthur Conan Doyle was actually a doctor, writes that when a doctor does go wrong, he is the first of criminals. He has the nerve and he has the knowledge. hopefully we're not so hard on ourselves anymore. I'll show you why. So I want to take a little detour to discuss the theory of reasoning, give you some examples, and then we're going to come back to a process of reasoning that we can teach and that we can deconstruct. So here's a 50-year-old man for you with a history of intravenous drug use and end-stage renal disease. And he presented with subacute fevers and was found to have sepsis, a new pansystolic murmur at the apex, and Osler's nodes on examination. And I say, what's the diagnosis? What's going on? And everybody who's listening to the talk immediately tells me that he's got endocarditis. So you immediately jumped to a diagnosis, and that's a way of heuristic thinking, intuitive way of making judgment. Other words applied to this would be common sense or rules of thumb. And I'll show you another case. So a 50-year-old man presents with malaise and arthralgias. He's found to be pyrexial and to have a tachycardia. What's his diagnosis? What's going on here? And you can see there is no way for you to recognize a pattern here that you could jump to a hypothesis, and you need another system, another mechanism to think, which is more analytical and structured to work out what the problem is here. And in fact, that's the dual process theory of reasoning. It consists of two systems of reasoning, which clinicians can utilize both of to correctly arrive at a diagnosis. And the first system, system one, is intuitive, while the second system is analytic. And evidence from functional MRI actually illustrates that distinct anatomical pathways are used when making decisions intuitively or analytically, different parts of the brain. And a careful balance between these two systems is necessary to ensure efficient and effective clinical reasoning. Experts often use heuristics, but still rely on analytic systems of thinking. And importantly, I'll show you later, no matter which way around you go, a calibration between the two helps you to reach the right diagnosis. So just to summarize, system one is intuitive, heuristic, it's pattern recognition, it's automatic and subconscious, it's fast, effortless, but it has low or variable reliability. It's vulnerable to error. It's highly affected by the context you find yourself in. There's a high emotional involvement and low scientific rigor. And system two is the analytical or systematic process of thinking. It's deliberate and conscious, it's slow and effortful, but it has high and consistent reliability. It's less prone to error, less affected by context, low emotional involvement, and high scientific rigor. Most of us live our lives using system one. For example, driving a car. I mean, can you imagine the cognitive effort involved if we always had to think about driving like we did in our first lesson? And we wouldn't be able to get through life that way. So after a while, driving becomes intuitive, automatic, subconscious. And diagnostic reasoning also follows that process of expertise being required before system one thinking gets to the right diagnosis. And then in evolutionary terms, these are forms of decision-making that are fast and shared with animals, where speed is more important than accuracy, and then those system two, which are more evolved and perhaps more distinctly human. And if you're interested in this, I highly recommend this very easy to read book by Daniel Kahneman. He's a psychologist and an economist, notable for his work on the psychology of judgment and decision-making, and also behavioral economics. And just to quote him, he says, "We humans constantly fool ourselves by constructing flimsy accounts of the past and believing they're true." And heuristics, judgment, quick calls, cause biases and errors. And I'll show you a few of those now. And they also cause overconfidence, illusions of understanding or validity. And so we might say, well, slow, deliberate thought, system two thinking is important, and that is true. But the areas of the brain that are most affected by internal factors, you're the regional call, sleep deprivation, fatigue, And external factors, distractions, cognitive load because you're on your 30th admission, etc. Those are exactly the ones that compromise system 2 systems and let us reach into our system 1 decision-making process and lead to error. So very affected by external and internal environmental factors. So let me take you through a few examples of these cognitive biases and human factors. Like I said, there are many, and many will be immediately recognizable to you, but it's often helpful to be explicit, to give it a name. And so you see exactly what it is and where you find yourself when you're trying to think about diagnosis. So let's start with an experiment. Look at this sentence for a few seconds. How many F's are there? Okay. So I'll say put up your hand, but everybody's sitting all over listening to this talk. But if I said to you, how many are there's likely a spread of answers? 2 F's, 3, 4, 5, 6. Here's the sentence again. And there are 6 F's, and they're highlighted. And now what's interesting about this experiment is that everyone is smart here, everyone can read English, we're all looking at the same thing. And I show this just to illustrate how the human brain works. That most often that V sound in the letter F in the word of tricks people's brains into thinking there's less F's than there actually are. And it's not common for people to actually recognize all 6 F's in the sentence. So if you got the correct answer, don't be smug. Something else will catch you out. Here's a quick look at another problem. See what you can come up with. A bat and a ball cost R1.10 in total. The bat costs R1 more than the ball. How much does the ball cost? And most people come up with 10 cents. And if you did that, you used your intuition, and of course you're wrong. The answer is 5 cents. I'll let you work that out later. So what's going on here? So this is really the human factors that we're discussing. To err is human, and this is type 1 thinking. I'm not giving you an opportunity to sit and work this out. That's your intuitive thinking, and your intuitions are wrong. So cognitive biases are subconscious errors that lead to perceptual distortion, inaccurate judgment, and illogical interpretation of information, prevalent in everyday life. As I said, to err is human, and they can broadly fall into one of these 4 main groups. Social biases, so peer pressure, the halo effect. Someone's good at one thing and you assume they're good at everything else. Memory biases, such as hindsight bias. Hindsight significantly impairs our ability to judge the quality of decision-making that occurred in the past. Decision-making biases, I'll show you some, and then probability or belief biases, and I'll show you some of that. So here's a few classic and common examples of this. Anchoring bias is also called premature closure. It's the failure to continue considering reasonable alternatives after a primary diagnosis is reached. And it's the most common diagnostic error. And I think it's probably the most, if not common reason why registrars fail their clinical fellowship examination. So when the diagnosis is made, the thinking stops. Premature closure. Availability bias is when one judges things more likely if they come to mind. So just because you saw it last week, you're far more likely to think about it this week and diagnose somebody with that disease this week. It's a little scary if we think that perhaps explain the classic statement that you've all come across, that disease or diagnosis presents in 3s. That's just because the first one made you think of it, so did the second one, and you spotted it the 3rd time. You've missed it all the other times. Confirmation bias is the tendency to look for confirming evidence to support a theory, rather than look for contradictory evidence to refute it, even if the latter is clearly present. So it's common for example, when you see a patient who's already been seen by another doctor, which happens a lot, of course, in a referral hospital setting, or you've seen it by another doctor who's more senior than you. Actually, confirmation bias is rife in everyday life. You know, in general, people read newspapers that already support their views, and you browse internet sites that mirror your own values, and you know, Twitter does it for you. You hang out with like-minded people, etc. So that's very prevalent. And then, of course, Sherlock Holmes, as an expert problem solver, knew that. It is a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories, instead of theories to suit facts. And another bias very commonly seen in our scenario of a referral hospital is diagnostic momentum, the tendency for a particular diagnosis to stick despite a lack of supporting evidence. And it kind of becomes stickier passed with increased certainty from person to person. I mean, this can happen all the way from a patient at home, you know, with chest pain, and the wife says, I think he's having a heart attack, and come to the casualty, and the nurse says the patient thinks the patient's having a myocardial infarction, and the doctor thinks, oh, it's definitely a myocardial infarction, and the patient gets admitted with a myocardial infarction to the ward. And of course, that patient had an aortic dissection all the way along. So that's a classic scenario. And it gets very sticky when it's written down in the notes, of course. So from one diagnosis to the rest, it just sticks all the way through. And I just want to mention this one, the unpacking principle. These all have names, so you know, all 50 of them have various names. We can look at examples, but I'm emphasizing this failure to elicit all relevant information to establish a diagnosis, because the history is so important in establishing a diagnosis. So the package is handed to you, you just don't unwrap it. Visceral bias is something we should recognize in ourselves. It's countertransference. It's negative feelings towards a patient might result in a diagnosis being missed. I think pause and think about this in yourself. Common types in non-adherent patients, or homeless patients, or that patient with chronic pain who's always complaining about the pain, obese patients often is, etc. So these are all examples of visceral bias. And again, Sherlock Holmes himself said so. The emotional qualities are antagonistic to clear reasoning. So one should recognize this in oneself. And then just a few examples, largely of probability pitfalls. And I must say, when I did this presentation, and this is the second time I'm giving it, I feel I want to divide it into at least two, with the second half really talk about diagnostic testing, where probability is easier to explain than in clinical reasoning. But this is really important, yeah. And you can spot these in the way people present on ward rounds or present cases in the clinic to you. Aggregate bias, where the aggregate data do not apply to my patients. Yeah? This patient didn't meet the criteria for, but I still made the diagnosis. That's a classic example. Base rate neglect, I'm going to discuss, ignoring the true prevalence. Sometimes in presentations, yeah, it goes like, this is a rare diagnosis, but it's first on the list. That's the classic spotting this base rate neglect. And you know, if there's comments about probability in presentations, be careful of the gambler's fallacy. The sequence of same diagnosis will not continue, etc. Yeah. Just to touch on base rate neglect, because I'm going to touch on it again briefly right at the end, when I try and put it all together into how you come up with a final diagnosis. We're very familiar with it, I guess, during the COVID era and during vaccination era. This is how the story goes in the vaccination and unvaccinated patients with COVID. If we look at this, the green on the unvaccinated and pink, purple here are the vaccinated patients who are hospitalized with COVID, and you can see there are more vaccinated than unvaccinated people in the hospital with COVID, and so clearly these vaccines really aren't good for you. And of course that completely ignores the actual prevalence, the base rate of the vaccinated versus the unvaccinated shown here. Very common mistake. And so the proportion of people in hospital who are unvaccinated is almost 50% versus only 10% of the vaccinated proportion in the population. The hospitalization rate is 5 times higher. And unless you see the background prevalence, you will miss that. And you'll see that in juniors, actually. Junior clinicians sometimes assume that because 2 diseases present similarly, they're equally likely to be present. It's, I guess, one of the reasons why in our setting, let's say we're presenting the HIV patient, while TB is always at the top of the list and lymphoma second. So yeah, the human brain is wired to jump to conclusions, see patterns that don't exist, miss things that are obvious, and our estimate of probability is also very poor. Here's another very good book that I can recommend by Rolf DeBelly, The Art of Thinking Clearly. The thesis is really around system 1 errors. James Reason, he of the Swiss cheese model of medical errors, I think put it very well when he said, good doctors are not those who don't make mistakes. Good doctors are those who expect to make mistakes and then they act on that expectation. And I think, owning up to the uncertainty and the errors in medicine is a huge part of it. The more we as clinicians pretend that we don't make mistakes, or we sell it to the population that way, or we say that our diagnostic tests are so good and they're not imperfect, the harder it is to acknowledge mistakes, and the less we seek them out, those specific mistakes. Okay, so let's with that background, deconstruct diagnostic reasoning. Let's look at a sort of a framework that one can use for teaching. And I've shown you this, this diagram and this framework before. Just put this up here. This is another version of it. Just remind me, it's very circular from the patient story to the generation of hypothesis to the diagnosis and back. But I'm going to use this framework from a recent publication, just because I like the pictures. And because it's an attempt to try and develop a standardized language that we can use, break this down into sequential, although it's not sequential, this process necessarily. But the 5 C's that's useful for students to spend time on perfecting each one of these. So the first one is collect the data gathering, history, and a physical examination. And we explore the history and the physical exam to generate a problem representation, which is a synthesis of the defining clinical features of the case, the initial problem representation. And we teach this all the time to students. Where does the data come from? Initial data, that's the folder review, history of presenting illness review, past histories, physical exam, and ultimately even testing. So all that data is gathered. I don't think there's a registrar who hasn't presented a case or sat in a clinic and discussed it and had the consultant say, please, where's the folder? And have you gone and looked at the old results? And why did you not print out the discharge letter from last time? And what about the CT from 2 years ago, etc.? So Sherlock Holmes cried, data, data, data. I can't make bricks without clay. It's really a foundation. And a very common mistake in diagnostic reasoning is that the data is actually not gathered. And the data is there. It already exists. And an important part of that data is that the data collection doesn't just happen in a single time. Most helpful, as I said before, for the consultant is history. And history is an iterative process. As the diagnostic process evolves and other clues appear, one returns to the bedside and asks further questions. I think we treat that very badly because we treat the process of history taking and examination sequentially, but it really isn't a sequential process. My favorite detective, or one of them, Harry Bosch, said, I've learned over the years that sometimes if you ask the same question more than once, you get different responses. Yeah. The registrar hates that patient who the next morning gives a completely different history on the post-mortem wardrobe. But of course, that's exactly how that phenomenon is exactly how it works. And I'm not going to speak a lot about examination in this talk, but it really is, I don't want to underemphasize how important examination is to making a final diagnosis. But importantly, for undergraduates and postgraduates, sometimes the focus is too much on the examination than actually what it means. You see, but you do not observe. The distinction is clear. So using the history and examination, you really come up with an initial problem representation, the way we organize the information we get from patients. The student or the learner must synthesize the history of data into a cohesive summary statement. It's incredibly important to make that short and sharp, to be able to focus exactly where you need to go on the next steps. And that takes practice, it takes a language. So, for example, a student might say that the patient presents with a painful swollen right knee that became 2 nights ago with attacks 2 and 9 years ago. Very common, but what we'd like him to say is that the patient presents with acute recurrent attacks of abrupt nocturnal severe pain and a large joint monoarthritis. And presenting like this and practicing is crucial. And I think, you know, when one's in an exam setting or a ward round setting, really, and somebody presents to you, I think one can get an immediate insight into their clarity of thought and their insight into the case. If the presentation is very good, the consultant is less likely to need to go back to the case to see what the actual problem is. They're very closely associated. Actually, Sherlock Holmes said it. He said, nothing clears up a case so much as stating it to another person. Very important. And this problem representation is a little formula that one can use, but I think one of the most crucial things I say to students is no more than 2 sentences, usually 1. Absolutely force brevity. Age and gender of the patient, the highly relevant past medical history, only the ones that are relevant to the diagnosis, the description of the primary symptom using semantic qualifiers. I'll share that now. You don't have to include everything here. What is the most important symptom of this patient and the reason the patient is in hospital or in the clinic? And then we synthesize that using clinical syndromes whenever possible. So a group of history and presenting features all together. You could even add tests in that regard. So, semantic qualifiers are paired opposites, medical terms that are paired opposites. And when you put that to students, it becomes much easier for them to actually understand what you mean and what you're expecting of the acute versus chronic, sharp, dull, bilateral, unilateral, constant, intermittent, etc. So if you add semantic qualifiers to problem statements, patient who presents with chest pain, you can immediately see how much more information it will provide if the chest pain is acute onset, severe crushing chest pain at rest, or if the headache is acute onset severe frontal headache. So very, very important to be able in 1 or 2 sentences define the key problem of the patient that you're seeing. And that's really the first step in data collection and initial problem representation. Using clinical syndromes whenever possible. So if a patient has confusion, the temperature 39, the heart rate of 120, respiratory rate of 24, elevated white cells, and positive cultures, that syndrome is severe sepsis. So once you can link these features into a syndrome, it becomes much clearer where you go next. Or jaundice, ascites, confusion, asterisk is hepatic failure. And then once you have a description of the problem representation, you search for matching illness scripts. Search in your head, that is. So let me just show you what that means. So knowledge organization is really important, actually. What's in your head? What's in my head as somebody with 20 years experience versus a junior 4th-year medical student or 6th-year medical student? What's in their head? So George Bordich said it very well. The development of a sophisticated problem-solving skill involves not only an increase in the number of facts, and make no mistake that knowledge is absolutely crucial, and that's why it remains the core of our assessment. But it's not only the number of facts, but a change in the way those facts are stored and used is really important. So a student kind of starts learning about medicine by learning about normal functioning, how do things work, then abnormal functioning, how things go wrong, then about syndromes, and then about disease, and then they store information that way. So they have sort of a filing system in their brain, and everything is filed under that. And how you file it depends a lot on how it was taught, and that varies enormously, even to date, between medical schools across the world, even across South Africa. You know, do you have a mechanistic approach to teaching immunology, neoplastic metabolism, or you know, do you file it by organ system, cardiology, pulmonary, renal, you know, like the textbook, or by disciplines, pathophysiology, is that still how it's based, pharmacology, biochemistry, and then you have this big pile of files and kind of a very disorganized filing system. That's absolutely typical of students when they come into the clinical years. And experts actually do that very differently. They reorganize their knowledge completely in a sort of a neural network, where signs and symptoms are grouped into syndromes, and syndromes are related to diseases. Okay, and actually you'll see, you know, that's kind of the first chapter of Harrison's, but very few textbooks are able to write it this way, because you can't write a textbook that links like this does into a neural network. And so this is something that's really important to teach and to explain as you teach students diagnostic reasoning. And this schema we need to use is the one that allows you to access the information in the clinical environment. That's the most important thing. And I'm not going to go too much into this because I don't really have the time. But for example, you know, the way it's organized is if a patient has signs and symptoms grouped into group category 2 here, the expert clinician will recognize that this patient has a syndrome, and there's another group of signs and symptoms that has the same syndrome and one of 2 possible diseases. But if the patient has signs and symptoms that fall into this category here, that overlaps with this, you will see that this top blue dot is automatically excluded. Okay, so that's not possible as a diagnostic option, and it can only therefore be one of these. So you immediately eliminate some options, and it's really based on the presence or absence of signs and symptoms. And how do you structure this in your brain is called an illness script. And expert clinicians have innumerable amount of illness scripts in their head, and most of them are built around this sort of approach: epidemiology, pathophysiology, symptoms, physics, and workup and treatment of a disease. This is the one for gout. So a person with gout is male, generally over 50. They can drink alcohol. They might have prior gout. They use good diuretics. It's urate crystals in joint space. The typical symptoms, physical exam. Workup shows the crystals and treatment. So you're well aware of this, but what's important to emphasize here is that the illness script include these characteristics. They include defining features of the disease. Okay, this is the bits that you'll find that students and inexperienced clinicians usually miss. Okay, so it's monoarticular. The first metatarsal laryngeal joint is the most common. That's a defining feature of this disease. It can be even more specific than that. Okay, they're discriminating features. So what makes this different versus septic arthritis? Systemic symptoms usually absent. Very, very helpful. And then there are pathognomonic features. If you have this, then you can't have anything else. Here it's on a test if you've got negative bioforensic crystals, but it can be on clinical features as well. So these defining, discriminating pathognomonic features are how a clinician stores an illness script in their head, using these to be able to distinguish between different, and that allows you to compare illness scripts of different diseases. And again, it's helpful to go through this with examples, but this talk really is a little bit about the vocabulary and the process, and I hope I'll encourage you to think and follow up on this a bit. So using the illness scripts, these knowledge structures that you use to store and organize disease, and these you develop with experience. It takes a lot of time to have a comprehensive set of illness scripts. Actually, you never quite get there. You then match the script using pattern recognition to the disease. You immediately spot it. This disease fits my script, or if you're not recognized, you use a system of analytic thinking and you can come up with the disease possibilities, and you develop an initial differential diagnosis. So you have an illness, a problem representation, You apply a diagnostic schema, which you match to the illness script, and that's circular, and then you can come up with a diagnosis. So the strategy is to make this initial differential diagnosis. I'll show you a few of those that you use. The first is what is most probable. So in my office, I most often see asthma as a cause of shortness of breath. So that's the most likely. Sorry, I want to acknowledge Rahul Patwari's YouTube channel for this and for these slides. Really a fantastic 6 or 8 series of lectures on diagnostic reasoning from an emergency physician educationalist at Chicago, Rush University in Chicago. So we know the most common causes is asthma, pneumonia, COPD, and MI in our setting, and so that's how we reason, and you have a list of other causes. Very importantly is to include in this process of formulating differential diagnosis, what can I not miss? Okay, in the emergency room, if I miss pulmonary embolism, heart attack, or tissue hemorrhage, the patient will rapidly die. So I cannot afford to miss that. Okay, that's it's an interesting discussion around the cases you presented about, let's say, HIV, TB, and lymphoma. You know, can you afford to miss the lymphoma? Is it okay, given the context of the burden of disease and the cost of treating and the response of therapy? And the overall patient's condition, or is it not okay? You know, you and I might differ on that, but I think that's a very important concept. What can I not miss? And cancer, terminal dangerous diseases, therefore must make the list of your differential diagnosis. If you're stuck, you can go to mnemonics. I mean, there are many of them. You know, Vindicate is one, for example, vascular inflammatory. I must say, this means that for every presentation, you then go and come up with a list of each one of these in no specific order. It doesn't allow you to sequence, etc. But it helps you make a list if you're stuck. So if you're short of breath, you might have pulmonary embolus, or you might have pneumonia, or if it's cancer, you might have lung cancer, etc. So that helps you differentiate. You can use anatomic frameworks. What in the chest can cause trouble breathing? Is it the heart? You know, is it the lungs, or is it blood? Anemia for our hematologists, and can use physiologic frameworks. How does dyspnea work? You know, hypoxia with VQ mismatch and small PE, or acidemia from DKA, they all cause dyspnea. And then the expert clinician, you can recognize him here. He's got the gray hair and glasses. So he goes, oh, I've seen this before. This is congestive heart failure. I feel it in my gut. Okay, that's the heuristic pattern recognition. And to be fair to the expert clinician, actually, although he might recognize the pattern, the expert clinician will go back and actually use all of these systems, depending on the individual case, to help sequence and organize the differential diagnosis. So the strategies that clinicians use, the tools you use, is really one of 3. Hypothesis testing is the linking of a single symptom or sign to a list of possible diagnoses, and then working through that list to see if one can refine that list. So it's commonly taught. For example, shortness of breath may have 50 causes. Which one is it? Is it 1? Is it 2? Is it 3? Start at the top, work your way down, and return to the patient every time to try and verify what it is. Forward thinking is much more helpful in advance, and that is simply, I guess, what we call an approach to. So it uses a sort of a branch chain algorithm to narrow down by getting more and more sequential information. If my patient's got low platelets or thrombocytopenia, and instead of looking at the whole list of causes of thrombocytopenia, I might ask myself if it's due to decreased production or increased consumption, and if it is that associated with coagulopathy or not? And if it is associated with coagulopathy, is it associated with other signs and symptoms, for example, fever and confusion or not? And so you can work your way through this branch chain, narrowing the differential diagnosis. And then pattern recognition, again, is, you know, the Aunt Millie problem. You see an old lady walking down the road and she's got gray hair and blue shoes and a necklace that I recognize. You don't ask yourself whether that's whose aunt is that, and could it be Aunt Millie or Aunt some other aunt you just recognize. Okay, so and all of these are helpful in various ways and are used. And then perhaps one of the actual reasons for this talk is to just introduce this concept of calibration, you know, or cognitive debiasing, having now illustrated how often we are wrong. And this is really a metacognitive checkpoint, that's thinking about thinking, where clinicians reflect on their thought process and identify and mitigate these cognitive biases, predispositions of thinking that can lead to errors in reasoning. You very often see, and I guess, busy work is one of the reasons for that, that people don't pause and think about their thinking and about their diagnosis. And I think the step actually makes a very big difference to ultimately having the correct diagnosis. So it's also called, taking a diagnostic time out, thinking about thinking, and just ask yourself, what else could this be? And is my thought process likely to be correct, or are there biases that could have been introduced because of various reasons? And then we confirm this by additional data collection, which can be clinical or it can be tests, etc. And in this process of confirming of hypothesis testing, in the clinical scenario, we apply positive and negative findings that are relevant to the framework. You'll be very well aware that we often say that the negatives really are what makes the case. What sells it in the clinical presentation is crucial to an ultimate diagnosis. Sherlock Holmes said, "Is there any point to which you would wish to draw my attention? To the curious incident of the dog in the nighttime. The dog did nothing in the nighttime. That was the curious incident," remarked Sherlock Holmes. The negatives are what makes the case. And then lastly, one uses the process of iterative Bayesian thinking, you incorporate probability into your differential diagnosis. And by the way, although I'm describing this stepwise, that's really for ease of description, breaking it down. These are circular and simultaneous. But it's really important to recognize that prioritization is important. And that really distinguishes the excellent presentation from the average one, is to get the list of differential diagnosis correct and the correct priority. And just from day-to-day work, that's crucial. It allows for targeted rather than a sort of shotgun approach to diagnostic testing. Testing and treating for high priority diagnostic possibilities avoids unnecessary cost and treatment, and it aids in the interpretation of subsequent diagnostic tests, because you're very well much more aware of false positives. You can avoid unnecessary follow-up tests or false negatives where you might discard erroneously the correct diagnosis. And the process for prioritization really requires estimating pre-test probabilities, setting thresholds, and then reasoning and calculating a post-test probability. And this you can do clinically. This is not just around tests. And in the interest, we just don't have that much time left. I'm just going to show you one or two examples of it, and then we're going to move in and close this up. But clinically, it's helpful to really tier your diagnostic possibilities into kind of high likelihood, moderate, or low likelihood. Clinically high likelihood is where the disease, your diagnosis, that is, explains all of the patient's major findings, where the patient has all the major manifestations of this disease that's in your illness script, and they have no rejecting features. They may have a key feature. Rejecting features are very helpful. If you have brisk reflexes, you don't have Guillain-Barré syndrome. Okay, so you can reject that diagnosis. Okay, and low likelihood really is the opposite. Patient has few features of the disease or rejecting features. You can reject it, and then you can come up with a pre-test, a clinical probability of the disease. And remember that testing, running tests, is most helpful in this middle range, less helpful in the top and the bottom range, because you're less likely to be able to change your ultimate decision based on where you test. So that's a very important concept in clinical reasoning. The most fundamental principle is that the interpretation of new information depends on what you believe beforehand. And when we just squiz through this and give you one illustration of this before I finish. So there's a patient that you're seeing at the clinic. And you want to test, well, let's say you don't see this patient in the clinic, because I'm not telling you anything about the symptoms and signs, okay? But if you want to detect a disease And this disease has a prevalence of 1 in 1,000. 1 in 1,000 people in Cape Town have this disease. But the test has a false positive rate of 5%. And what is the chance that this person you're testing who has a positive result actually has the disease? Assuming you know nothing else, okay? No pre-test abnormality. And a lot of people say 95% chance that you have the disease, okay? And in the simple 2x2 table, just show you that in fact that is way out. So the false positives are 50 in 1,000, and only 1 in 1,000 actually has the disease. So a positive result is only a 2% chance of being correct. Okay, so there's a profound impact on the background prevalence on what a test result means. And this is equally true when you run a test or when you come up with a clinical diagnosis. Test result by itself is not the answer. And the prevalence of the disease was very high or very low. That has a profound effect. Okay, and then the last step is commit or continue, which is really where you do ongoing decisions and investigation, and you can set treatment and testing thresholds. And I'm just going to again refer you to the YouTube video that I referred before, and you can think about this. And so to finish off, to one slide and then a summary. So I just want, I'd like to refer you to this paper here, Understanding and Communicating Uncertainty in Achieving Diagnostic Excellence, which I've briefly discussed before, that we need to be very clear that diagnostic uncertainty is common and should be shared explicitly with patients. A failure to communicate uncertainty actually contributes to diagnostic error because it puts you on one path and rather difficult to sway you from that path. Understanding diagnostic uncertainty can be enriched by incorporating perspectives from medicine, social sciences, humanities. We haven't touched on that, but I think it is difficult. Actually, I find in my own family they struggle to understand this concept and think that doctors are 100% right or wrong. And it should be reimagined as positive and routinely embraced in clinical care and in education. And explicitly acknowledging, managing, and communicating uncertainty promotes a very robust diagnostic safety culture. And in the last talk, Graham Mankey's also said, well, the way we write notes, for example, really doesn't do this. We need to think very carefully about uncertainty and acknowledging it. So I hope to some extent I've given you the framework and the language to understand your own diagnostic reasoning process and hence convey that to others. And I'm going to finish with a checklist, given that a checklist has been shown to save lives, for example, in theatre. And so let me give you a checklist for diagnosis. Obtain your own and complete medical history, data, perform a focused and a purposeful physical examination. And most diagnosticians, expert diagnosticians, have made a diagnosis within the first 3 to 5 minutes. Okay, that's a really important concept, but that's very, very difficult without expertise and experience. Generate some initial hypotheses and differentiate these with appropriate additional questions, exam or tests. And then pause to reflect. So take a diagnostic timeout. Ask yourself, was I comprehensive? Did I consider the inherent flaws of heuristic thinking? Was my judgment affected by any other biases? Importantly, do I need to make the diagnosis now or can I wait? That's quite helpful when you're on intake at night and needing to admit patients for tomorrow. And then remind yourself, what's the worst case scenario? What are the do not miss entities? And then embark on a plan, but again, continue to acknowledge uncertainty and ensure there's a pathway for follow-up. And Gosha Ayoma, seeing I've been dealing with detectives, he is a manga writer of the fictional detective Coleman in manga comics. That's the most widely read detective in the world. Said the following: detectives, and that's to some extent what this is about, detectives are only human. We're not gods that know everything. When detectives tell their theory, in reality, most are rather anxious, thinking that there's always the possibility that they could have missed something somewhere. But in return, the excitement you experience when your theory is smack bang correct is twice as great. Thank you very much, and I'll finish with that.
Peter, thank you so much. I must say, talking about metacognition, you've certainly given us a lot of food for thought on thought. and our thought processes. Prof. Johnny Mshlangu has got his hand up. Johnny, please go ahead.
Absolutely. No, thanks, Peter. Very thought-provoking and certainly very enlightening. I've got two questions. One is, in the era of artificial intelligence, which we know reduces the requirement for manpower, it is possible, it is portable, it is reliable, it is cost-saving. Do you think that there is still a role for an expert diagnostician? The second question relates more, do you make a distinction between a clinical diagnostician or an assisted diagnostician? In other words, someone who uses, for example, I'm a hematologist. I rely on the full blood count to tell me how low the hemoglobin is, as opposed to looking at the patient and try to gauge how pale they are. And similarly, imaging such as CT scans and X-rays. Do you make that distinction, or diagnosis is diagnosis? It doesn't matter what tool you're using.
Thanks, Johnny. I mean, look, I'm not going to say AI is not going to become better than us, but like I mentioned in the talk, IBM have actually tried putting their biggest and brightest computer, IBM Watson, on the task, and it's been reasonably poor, actually. I think one of the great difficulties and you'll recognize this as a diagnostician, is you've got to get the right data from the patient. If the data is not required from the patient, but from elsewhere, so you might, for example, say the data I require is actually from the full blood count or the smear, I think that is potentially a very different scenario. But I think if the data is required from the patient, it needs still today to that clinician to be sure what that patient's actual complaint is, what is the actual problem, and how do you go from there. So I don't think computers have been able to solve that problem yet. But of course, I mean, they may well in future. And as you're well aware, they're already certainly on the diagnostics track of solving quite a lot of problems using AI. So I think that's the first thing. The second thing is I sincerely hope that medicine always remains a human to human interaction. I think management decisions are very far from being algorithmic and computer-based, and rely a lot on preference, on pros and cons decisions, etc. And for that, you also will need clinician interfaces. So I personally don't think that a computer will replace a human when it comes to diagnostic, but there's no question that it'll be an aid. Absolutely. You know. And I do think reasoning when it comes to diagnostics, I mean, I focused a little bit on clinical diagnostics. This is a talk about history and examination, but it's absolutely no different if you include tests. So no, I don't really distinguish between that at all. I think if you send a full blood count and you don't know what you're asking of that full blood count or what you're looking for, you're also likely going to get the wrong answer. So I think the approach to reasoning, diagnostic reasoning in the setting of laboratory or any other test is identical, really. I don't think it's any different. I didn't touch on that in great depth in this.
Thanks, Peter. That's great. Matthew, aka DX3GL3CY from Vancouver, Canada. Prof. Matthew Seftel, I think that's you.
Oh, hi, Vernon. Yes, this is me from Vancouver. So big thank you for that talk from Prof. Robenheimer. It really was excellent. And I'd like to emphasize that the content of that talk would have been well appreciated and relevant in any region and any jurisdiction in the world. That could easily have been given at a deep dive here in Vancouver and had 100% relevance. So thank you. I do want to just maybe emphasize one point that Peter made, which is that when it comes to the importance of accepting and addressing biases that we all know we are going to have as we look after patients, the various biases that you mentioned, is that one of the best ways of mitigating that is teamwork, because those who work in teams know that each individual team member will have a different perspective, a different experience, different knowledge, and different biases. And that it's fine to call out people if you suspect that they are their thinking is subject to bias. And that means that it's sometimes fine for a medical student to call out a registrar, or a registrar to call out a consultant, and that one's level of training and age is not always completely correlated with diagnostic accuracy. And I've experienced many situations where the most junior member of the team may have an appropriate perspective, but they're sometimes too shy or embarrassed to call it out. So teamwork is a very, very important way of addressing many of these biases.
Thanks, Matthew.
Yeah, thanks so much for that comment. I couldn't agree with you more. And again, I've experienced exactly the same thing where the medical student who actually had more time with the patient than any of us actually had the right data, and never mind the diagnosis. And you're absolutely right. Flattening of the hierarchy in the team is crucial for patient safety, to avoid errors, etc. And I think it's something we've worked on, and the world is changing. So I don't know if we're there yet, but it's really important to emphasize that. I appreciate your comment very much.
Yeah, that's. I just want to add to that. That's really great, Matthew. And I think having academic ward rounds where there's an openness for people to speak up and to share, and like both of you have just said, where the hierarchy is as flat as you can possibly make it. I often find that at the end of a ward round, there's so many things that the registrars and fellows think of that I did not think of, that sometimes is scary almost. You start thinking about retirement on those days, but it's really important to work as a team and allow the team to really feel like they are part of it. And that book, Outliers by Malcolm Gladwell, that I'm sure many have read, is so good at showing where the power distance is too great, where people feel intimidated, where they feel, some of the older style of doing things from 100 years ago. That really leads to plane crashes and, in our world, disasters. So thank you for that. I thought that's a really great comment. I see there's a comment here from Estelle. I agree with Johnny that as hematologists, we have a fast track to certain tests and even imaging already done. An unfair advantage we have in certain diagnostic approaches. That is the nature of our subspecialty roles, and the referrals to us is a challenge, not also how we translate our inside knowledge to the other diagnosticians to enable them, as well, of course, better facing and dealing with our own deficiencies and biases. Take note of changing the cockpit dynamics, which Prof. Mark Blockman mentioned in his comment just before. And I guess, Mark, you are referring to the same book, if I'm not mistaken. Is that right?
No, so Vernon, what's happened I'm sorry to butt in without asking permission.
Please.
So what's happened, if you remember the various aeroplane accidents that have occurred, there's been a note that the hierarchical system in the cockpit has in fact derailed the ability to have safety. And so there have been numerous writings around that and how to rectify that. And the one way is to make sure the co-pilot has opportunity to question the captain. And that has also moved into the surgical discipline as well, where there are checklists within theaters in terms of preventing adverse events and preventing, for example, leaving swabs in. And so now it's not uncommon for the senior clinician to be questioned by the nurse practitioner, for example, to say, look, this is what's occurring. And that is allowed for a safety environment, which wasn't held before. So yes, I'm all in favor of what you've just suggested, that there's no hierarchical system and a flattened authority to prevent patient harm.
Great. And for those who want to learn and read more about these aeroplane accidents, It's quite fascinating how Malcolm Gladwell describes this whole thing in that book, Outliers. Very, very good. Let's see, we are reaching the top of the hour. Just to remind everyone again, or the top of the end of the meeting, in the chat box, the link is there for you to register your presence for CPD purposes, if that is important to you. From my side, unless there are any other comments, and I did notice some interesting conversations going on in the chat box. But thank you so much to Herman Bagula for a great introductory to cases. Thanks, Peter, for a very enlightening talk. I learned a lot and I really enjoyed it, and I'm sure many others did. And thank you to all of you who attended. Just to let you know, next week we will welcome Prof. Johnny Mshlangu and Susan Lowe from WITS, who will talk about the prophylaxis issue in hemophilia, which is very, very topical. As you know, there's just been a paper out in the SAMJ on what the standard of care should be in hemophilia prophylaxis. And I look forward to a really vibrant discussion next week, and to see all of you here. So with that, I think today we're nicely in time with 2 minutes to spare. I wish you all a wonderful and a good evening, or morning, or afternoon. Bye-bye.
Thanks, Herman. Bye-bye.
Thanks, Peter. Thanks, Herman.